Good evening. My name is Peter Nilsson from the Lund University in Sweden. I'm very grateful for the kind invitation from Professor Kotsis to ask me to speak on SGLT2 inhibitors as the first step in type 2 diabetes therapeutic protocols. And I would like to review this topic for you. Here you see my disclosures. I have no position, stocks, or financial interest in any pharmaceutical company. I give lectures to many companies, as stated here, and as a representative of my university, I try to give a balanced view on the research and recommendations, the so-called third task of the Lund University. Let's focus on SGLT2 inhibition. You all know that the consequence of that is glucosuria, natriuresis, and some blood pressure reduction. In the end, there is also cardiovascular protection and prevention of renal impairment. There are different SGLT2 inhibitors, empagliflozin, dapagliflozin, and a few others. The consequence is a glucosuria of approximately 70 grams per day through this drug effect. Interestingly enough, the research in this area started years ago to find natrium glucose co-transporters to better understand childhood diarrhea or diarrhea caused by cholera and other similar disorders. That was the starting point to invent oral rehydration solution to save the lives of many children with diarrhea. Later on, these receptors were characterized, they were mapped, and it translated into the possibility to inhibit these receptors, SGLT2 receptor inhibition. So coming all the way from diarrhea in children to an effective anti-diabetes treatment in type 2 diabetes, it has been a long way, but the consequence of this drug effect is the glucosuria up to 70 grams per day, but also losses of sodium and fluid. On this slide, you see a number of effects of importance to understand the mechanism of SGLT2 inhibition. I will not go into all the details, but there are many fascinating aspects. And personally, I'm very interested in blood pressure reduction, normalization of central hemodynamics, and also reduction of arterial stiffness. However, other actions of great importance is improvement of cardiac metabolism and also some other consequences, reduction of chronic inflammation, for example. Here you see a timeline for SGLT2 inhibitor studies with hard endpoints. I will not go into all the details, but as seen here, there are at least 6 studies for investigating the protective effects on cardiovascular endpoints in type 2 diabetes. One in CKD with or without type 2 diabetes, and 5 in heart failure with or without type 2 diabetes. Of course, these studies include a number of primary and secondary endpoints, but according to this list, we see the primary design of the studies. The pioneer study, very well known, was EMPA-REG in 2015 in patients with type 2 diabetes at high cardiovascular risk, secondary prevention. And as seen here, there were many substantial beneficial effects that sparked a lot of interest. That has now been ongoing for 7 years, and it's a continuing story. On this slide that I have been given by Professor Lars Rydén, you can see a summary of the cardiovascular outcome trials, listing 4 different ST2 inhibitors: empagliflozin, canagliflozin, dapagliflozin, and ertugliflozin. And as you can see here, they include a shifting number of patients with a previous CVD, less so in a DECLARE study with dapagliflozin, and a follow-up of a few years. Empagliflozin and canagliflozin reduce significantly the primary cardiovascular endpoints of borderline significance for the other 2 gliflozins. But for heart failure hospitalization, all drugs could provide a benefit. However, total mortality was reduced only with empagliflozin and canagliflozin, not significantly with dapa and ertugliflozin. Another summary slide show you the summary effect on a number of endpoints: 3-point MACE, cardiovascular death, all-cause mortality, heart failure hospitalization, and a composite renal endpoint. It's important to know that for heart failure in all trials, there was a rapid onset of effect, similar magnitude, and seemingly a class effect. For the other endpoints, the outcome shifted, and I remind you that with dapagliflozin DECLARE study, there was also a high proportion of patients at high cardiovascular risk according to risk factor levels, but not secondary prevention. So if we compare SGLT2 inhibitors and GLP-1 receptor agonists, there are some similarities and dissimilarities. Shared properties include glucose lowering, weight loss, blood pressure reduction, and renal protection, more so with the SGLT2 inhibitors, and separate effects for the GLP-1 receptor agonists, slowing atherosclerosis, plaque stabilization, and especially for SGLT2 inhibition, heart failure reduction, and renal protection. Together, they can improve cardiovascular and renal outcomes. And in fact, they can even be combined, even if this is a rather sophisticated and expensive way of treatment. In 2019 came a systematic review and meta-analysis of cardiovascular outcome trials involving SGLT2 inhibitors for primary and secondary prevention. It showed in another way what you have already seen, that the effect on cardiovascular composite endpoints was significant in patients with a previous atherosclerotic cardiovascular disease, but not fully significant in patients with multiple risk factors. However, if we look upon heart failure and cardiovascular death, the pattern is about similar, but a trend also for benefits in patients without previous CVD, but with multiple risk factors. And for the renal endpoints, we see benefits in all studies, irrespective of previous CVD or not. This is a more updated systematic review and meta-analysis from 2020. And as you can see here, the totality of evidence is in favor of treatment with SGLT2 inhibition for renal protection. But we also have some real-world observations from very large observational studies, not randomized, but observational studies based on clinical practice. So this slide shows you 3 observational studies with a smaller proportion of patients with the previous CVD, as can be seen here, but with a substantial number of person years under observation. And the striking effect is the lower risk of heart failure hospitalizations, as indicated here in green. Also for total mortality, there was a significant benefit in these observational real world studies. So let's take a closer look at heart failure. There are many mechanisms involved to improve cardiovascular outcomes: altered adipocane regulation, autophagy induction, improved cardiac ionic homeostasis, improved myocardial energetics. And I would like to add to that the effects on hemodynamics, blood pressure reduction, and normalization of central hemodynamics. A few studies, dapagliflozin in patients with heart failure reduced ejection fraction, randomized dapa 10 milligram versus placebo in more than 4,700 patients with or without type 2 diabetes, but with heart failure with restricted ejection fraction. And dapa could show a beneficial significant effect as seen here. That started, in fact, very early. And this was significant both in patients with and without type 2 diabetes at baseline. So it's a good study to show benefits of SGLT2 inhibition also in patients without diabetes, at least for heart failure. Another study, empagliflozin in heart failure with a preserved ejection fraction. Also for this group of patients, SGLT2 inhibition proved to be very useful to protect from a composite primary outcome and also for hospitalization for heart failure. However, there are a few critical remarks, some caveats that should be remembered. For example, there was an increased risk of toe amputations with canagliflozin in the CANVAS study, and my personal view is that these drugs should be avoided in patients with foot ulcers, as seen here. Another problem is normoglycemic ketoacidosis, a rare condition, but these drugs should be avoided in patients with cachexia, and we should pause drug in case of dehydration, similar to pausing of metformin and renin-angiotensin system blockade therapy in such cases. We should consider insulin in patients with weight loss and hyperglycemia, because then SGLT2 inhibition is not the drug of choice. We also know that there are some side effects, for example, infections and dermatitis, etc. But I think these side effects are well known. However, normally these drugs, in fact, are well tolerated, and the shortcomings, the side effects are not so common. So finally, a look at the guidelines. These are the European Society of Cardiology guidelines in collaboration with the EASD and other organizations. As can be seen here, that SGLT2 inhibition or GLP-1 receptor agonist is recommended in patients with type 2 diabetes at very high risk or multiple risk factors. So metformin has been drug of choice, first-line treatment for a long time, but the evidence is not that strong. So if there is target organ damage, if there is a case of previous CVD or very high risk factor burden, I think there is a good argument to start with one of the modern anti-diabetes drugs, SGLT2 inhibition, especially because it's easy to take, but also GLP-1 receptor agonist is useful. Now also possible to have a peroral formulation. So according to these guidelines, in persons with type 2 diabetes and atherosclerotic cardiovascular disease, the newer drugs have received high marks for class effect and evidence base. So they should be more used. And for heart failure, the most recent ESC guidelines recommend SGLT2 inhibition together with the more standard therapy, RAS blockade, beta blockers, and mineral corticoid receptor antagonist. So in summary, SGLT2 inhibitors are mostly safe, well-proven, and effective drugs to prevent cardiovascular disease complications and renal impairment events in type 2 diabetes at high risk. Recent trials have documented a very good protective effect also in heart failure in patients both with and without diabetes. The recent guidelines put a strong emphasis on the newer anti-diabetes drugs, especially SGLT2 inhibitors, when there is high cardiovascular risk with or without metformin. We should also remember renal protection. So in the end, these drugs are useful and they can be considered as first-line treatment in specific group of patients. Even the combination of SGLT2 inhibition with GLP-1 receptor agonist drugs could be considered in some selected cases. Thank you very much for listening.